So I'm going to be talking about the topic I was assigned is treatment of asthma phenotypes. So I'll be going over discussing asthma phenotypes as well as different biomarkers to treat asthma phenotypes as well. Faculty assisted me with this is Dr. Tatum, so thank you very much, Dr. Tatum. And so disclosures, wait, the slides are mine, shoot, but the images are not all mine. I have no other disclosures. I apologize for that. So some of the objectives, I guess a better understanding of asthma phenotypes, discussing IL-5 and IgE. Those are the two biomarkers I chose to discuss. And then also the different therapies against IgE and IL-5. So just a quick asthma overview. Mike Harrison gave a talk about asthma last week, so he stole like about 10 of my filler slides at the beginning. So in 2010, this data is mainly from the CDC, approximately 1 in 12 adults reported asthma. It cost the United States about $56 billion each year, so it's very expensive. Black adults are hospitalized for asthma more often than white adults. I put that out there because we practice in a city that is 84% black, so very important to keep in mind when you see these patients. 1 in 4 black adults cannot afford routine doctor visits, so for follow-up and management of these things, and that's also really important. As you guys follow the news, there's repeal of the Affordable Health Care Act. When that went into place, about 6.8 million African Americans gained coverage for health care, and if this is repealed, I don't know how 6.8 million changes the numbers on this. Not talking politics, but I think it's really important to keep that in mind because it affects us and how we practice things, especially in this community. So this number could go up. So looking at this of, who's treating asthma today? I remember when I went to Grand Rounds last year, we had a pulmonologist from U of M, and he was talking about COPD. And, primary care physicians see a lot of bread and butter asthma. More than 10 million patient visits for asthma. 85.5% were to a PCP. It's roughly the same for COPD. Another group is allergists. They deal with asthma a lot as well. Some of our pulmonary patients who have asthma, you'll go through their notes in Epic, you'll see a lot of notes as well that they've been seen in the allergy clinic. Emergency medicine doctors, they treat a ton of asthma for exacerbations, as well as some people in the community can't get to a PCP. I've gone down to the ER when I was a resident. Who's your PCP? They point to the ER attending walking by because they come to the ER so frequently that they see him as a primary care doctor. And then, the people in this room, pulmonologists, we see a good majority of asthma. So this is just hot off the press from JAMA, reevaluation of diagnosis in adults with physician-diagnosed asthma. This is from Canada. They called in the 10 largest cities of Canada, about 17,000 people questioning them about asthma. They ended up with a population of 710 patients who were willing to participate. And of those 710, only 613 were willing to kind of go through and participate in the study. So one of the things I pointed out that I like to point out in this is, the asthma diagnosed by the family medicine or ER doctor, when they went through and confirmed this with either spirometry or methacholine challenge, of the 410 where asthma was confirmed, 230 were diagnosed by a family medicine doctor or ER doctor. All right. Whereas the pulmonologist, allergist, and internist and pediatrician are also grouped into a place where some of the groups that these guys saw, 138 by family medicine and ER was ruled out, and that was significant. Overall, 203 patients that were told they have asthma, when we went back through and looked at them, they actually didn't have asthma. So, and when they looked at that group of people, 181 of that group was not formally tested with spirometry, methacholine challenge. It was all just clinical assessment. So, we have to wonder, do these patients need to come see us? Also in the day of EMR, we're busy, we see a patient, we look at a problem list, it says asthma, we roll with it, and then we kind of just tether on to that diagnosis. So We need to be more diligent in looking at that. So from the time I started medical school, when I look at asthma, you always see this chart. You think about it as in severity. You have your intermittent, your mild, persistent, moderate, persistent, severe, and you go through and you ask the patient, how often do you have symptoms? And based on where they're at, you step up the therapy and you go from there in treatment. So I staff a lot of times in the clinic with Dr. Morris and Dr. Ouellette, and one of the things they always tell me is, some of the things I said before is, PCPs and, general medicine doctors, they can treat asthma. You're a pulmonologist. Yeah, you see this and you think it's asthma, but they're here for a reason, so you got to do right by them and think ahead. Could it be something else? What else could it be thinking about? So, for this talk, we're going to not focus too much on this and move on from it. So, the asthma umbrella, generally present in asthmatics, airflow limitation on spirometry, airway hyperresponsiveness to challenges, and some of the symptoms, the shortness of breath, cough, wheezing, chest tightness. But there's also a lot of heterogeneity in asthma. There's variation to the degree of airflow obstruction. Not all respond to the same treatment. 30 to 45% of asthmatics don't respond to inhaled corticosteroids. And there's no set script for how any of the triggers cause them to react. So, somebody who is diagnosed a moderate persistent asthma may not have gotten there the same way as somebody else. So there's different things that trigger them, and that's a lot of the different things that are discussed when we talk about phenotyping. So some of the phenotypes that we'll discuss are cellular, clinical, and molecular. So going over cellular phenotype, it's based on sputum cytological analysis. So there's eosinophilic, the neutrophilic, mixed eosinophilic and neutrophilic, and paucigranulocytic. This is from Halder. They look at clinical phenotypes in a way similar to what I'm talking about is who treats asthma. So they have symptoms on the y-axis and eosinophilic inflammation on the x. And the way they look at it is they're kind of discussing who should be treating these patients based on symptoms. The yellow is primary care, and then the blue is a secondary care physician, a specialist like us, or even an allergist. So when you have the discordant symptoms where a lot of symptoms but you're not seeing inflammation up top, that's somebody who should probably go to a specialist to be treated for asthma rather than a PCP who will just look at them and say, oh, you're moderate persistent or severe persistent, try this therapy, rather than going maybe the extra step in discussing. And then the inflammation predominant. There's a good amount of people who have high eosinophilic count, but they may not be symptomatic, and they need to see us. And then there's this group of the early onset atopic, and that's kind of a group that you have to kind of figure out where they're at as far as inflammation and where they're at as far as symptoms. So the further they get more symptoms, more inflammation, the more likely they need to go see a specialist rather than they fit in the step up of moderate, persistent, and so on. So one of the things that looking at is describing this cluster. So this is a study done, the identification of asthma phenotypes using cluster analysis and severe asthma research program. When I read through this, it was interesting to see how they grouped the asthma population as they broke it down. But one of the things I never got to is, and they discuss at the end as a tool, is how does this help us decide treatment? And they don't really discuss that at the end. They're saying that this is an algorithm that maybe down the road we can use to discuss as treatment. So asthma phenotypes as clusters is going to be the heading for most of these as I break down. There's 5 clusters. So cluster 1 is predominantly young females, childhood onset, atopic asthma with normal lung function. 40% of these people are not receiving controller medications. Their healthcare utilization, meaning their requirement of burst or oral corticosteroids or their visits to the ER are very limited, but they still report daily symptoms and rescue bronchodilator use. Cluster 2 is older subjects, 2/3 of which are female, and they have primarily childhood onset atopic asthma. Looking at their lung function, when you break them down, pre-bronchodilator, 65% of these people had FEV1s that were pretty good. Of the remaining of that group, 94% of these people could be reversed with bronchodilator therapy. So less patients in this group are not on controllers. So a lot of them do have controller medication. 28% on high-dose corticosteroids, but at the same time, they report the healthcare utilization and asthma symptoms similar to group 1 that is doing fairly well. So cluster 3, women with a mean age of 50 years old, because it labeled it in the study as older women, and I don't think that's older as a disclaimer. So they have the highest BMI. 58% of these women have a BMI greater than 30. A lot of them have late onset asthma, and as a majority of them, their baseline FEV1 is less than 80%. Their utilization of medication is really high. A lot of them are using 3 or more medications to control their asthma, and then requiring regular systemic steroids. And they're really, when we look at their degree of obstruction and what's going on with them, it's out of proportion to how they use the healthcare, utilization. They're more frequently visiting the ERs, they're more frequently getting hospitalized and requiring systemic corticosteroids. And then cluster 4, this is when we get into our group that meets ATS criteria for severe asthma. There's 120 people. It's equal. This group is equal in gender, almost split 50-50 between male and female. So their FEV1 is, 57% of them, their FEV1 is really low, but 47% of them are able to reverse to greater than 80%. And I put the asterisk there because they're able to reverse with 6 to 8 puffs of albuterol. So I think that's a lot of albuterol use to reverse, whereas when we tell people to use their rescue inhalers, or we're telling them to use 1 puff, 2 puffs for symptoms every 4 to 6 hours. These guys are requiring a large amount of albuterol use. They also have high healthcare utilization. And then 25% of them report hospitalization for asthma, and then another 40% report ICU admission for asthma. And then we have cluster 5, another group that meets ATS definition for severe asthma. This group has some of the longest duration of asthma. Most of them have had asthma for over 29 years. The majority were females with older onset, and this is the group that had the most severe airflow limitation. Their mean FEV1 was less than 43%, and the majority remained below 80% without max bronchodilator use. 47% of this group was treated with oral corticosteroids, and they also had high healthcare utilization. When we looked at this group, very similar to the group 4 cluster, looking at hospitalization and ICU admission. So some of the things that they broke down, because trying to figure out the goal of this is, can we make an algorithm, the way I understood it at least, to guide treatment. So then they did a biomarker distribution of the clusters. So looking at serum IgE, it's highest in the atopic clusters, which were cluster 1, 2, and 4. And then the sputum eosinophils were highest in 3, 4, 5, where neutrophils were highest in group 5. So clusters 3, 4, and 5 had persistent airway eosinophilia in the setting of high-dose inhaled corticosteroid and oral corticosteroids. So the question is does this group, which has some of the highest healthcare utilization, exacerbations, use, and irreversibility, difficulty irreversing the FEV1, does this group have some sort of steroid insensitivity? Going off the model where you step up, you would eventually just run into a wall with this group until you decided to, treat a biomarker. So this is one of the ways that they looked at their clusters, and I didn't have a chance to put the colors up, but I wrote them down. So blue is mild atopic, and then green is mild to moderate atopic, with the yellow being late onset, non-allergic asthma. The orange is severe atopic, and then orange is severe atopic, and then the red being fixed airway obstruction that's very severe. And that's the way they kind of broke down how that kind of phenotype fits amongst those clusters. Kind of confusing. Thought it was interesting. I thought I'd put it up. So going over molecular phenotype, which sometimes is also referred to as endotype, the asthma molecular and cellular overview, it's a type 2 immune response in the lower airway. You have the Th2 CD4 cells, your type 2 cytokines, which are interleukin 4, 5, and 13. They promote IgE-mediated hypersensitivity, which leads to an activated epithelial cells, and then you have an influx of inflammatory cells, can lead to remodeling of the epithelial and subepithelial matrix. Just a brief overview on that. So going over IL-5, a medication that's something that's being discussed as a hot topic in the treatment of asthma. Protein that's secreted by activated Th2 cells and mast cells, and then it's notorious for its action on eosinophils. It creates the differentiation of them from the bone marrow, causes proliferation of the eosinophils, the migration into the airways, activation, and then via binding from selectin and other adhesion molecules, survival within that airway. And it acts by an intracellular cascade by way of JAK2 and STAT5. And here's just a cartoon going over how this kind of works. You can see here, I think that's there. So your eosinophils, the IL-5 is acting here on the bone marrow, causing some differentiation of the eosinophils. When they come down, they bind in this airway, in the endothelium, to selectin, and then the VCAM, ICAM causes them to actually have some adherence, and then they can migrate out of here and just cause more proliferation. So one of the ways that works. So, importance of 1990, they caught Manuel Noriega, he surrendered. Buster Douglas knocked out Mike Tyson, never thought that would happen. Smoking was banned on flights that were longer than 6 hours. The Pistons won their second title. And then this molecule, IL-5, was being investigated more for the treatment of asthma. So that's like the most important thing to me that happened in 1990. So the IL-5 eosinophilic connection, Dent et al. Looked at transgenic mice. They found that transgenic mice with overexpression of IL-5 had profound peripheral eosinophilia and eosinophilic infiltrates within the lungs. So they thought that the activated T cells were thought to be the source of the IL-5, and then they looked at mice that were deficient with IL-5, and they didn't find any airway hyperresponsiveness when challenged. So then, they noticed that IL-5 levels were normalizing after treatment with systemic glucocorticoids. So I'm just kind of laying down a timeline of how this all went down. So IL-5 is a crucial cytokine that influences circulating eosinophils, airway hyperresponsiveness, and pulmonary inflammation. So going back to, the chalkboard or the drawing board, so the question is, will targeting IL-5 be a potential treatment for asthma? That's what a lot of the guys were asking themselves in the research. So, all these drugs are MABs. The mob has Cosa Nostra. That's asthma in Italian, so asthma nostra. So this asthma of ours, it's a MAB story, starting with the IL-5 antagonist. It's corny. You guys don't all have to laugh at once. So a clinical scenario, all right. You have, in clinic, a 42-year-old man with lifelong asthma. He has significant environmental allergies, frequent exacerbation. He reports daily symptoms with frequent nighttime awakenings, which require albuterol MDI for the relief. He has proper inhaler technique and an action plan. His current medications are high-dose fluticasone and salmeterol twice daily, and albuterol is needed. He's needed 3 extended courses of oral steroid therapy for exacerbations over the past year. He's allergic to dust mites, cats, mold, and trees. Allergen desensitization has not been effective. So physical exam is normal, except for scattered wheezing, and the lab tests reveal a white blood cell count of 8.2, 8% eosinophils, and an IgE of 320. PFTs reveal a FEV1 of 65% predicted, and the chest X-ray is normal. So there was supposed to be a poll here, but I didn't really figure out how to get it to work. So my question to you guys would be, what kind of treatment would you want to pursue in this guy? Not all at once.
He's not on any inhalers?
He's on combination, and he's using albuterol as needed. And he's been requiring more oral steroid use.
So he qualifies for interleukin-5 inhibitor with his IgE level?
I would say yes. Yes.
He does qualify for Mepolizumab.
Correct.
Based on his IgE or based on something else? Some
Do
other
you look at the percent or do you look at the total number?
Other than the frequency of observations, he needs an IgE level of 150 with a negative. I'm talking about Mepolizumab.
Right. So you're confusing anti-IL-5 therapy with
So
Xolair.
one of the things, though, but he brings up the number 150. So it's greater than 3% eosinophils and an IgE that's greater than 300. But one of the things I read is an IgE level greater than 150 with a duration of 6 months treatment. Does that sound correct? It didn't really make sense to me. I like just the simple term. Yeah, Jasmine.
Is it the IgE level or is it the eosinophil level?
It's
So-
the eosinophilic.
Well, yeah, sorry.
Oh, yeah. Sorry.
So it's an absolute eosinophil count greater than 300.
Absolute. Yeah, sorry, I misspoke. The eosinophil. So,
150, I'm sorry. Not 300, 150.
Correct.
Thank you.
So Mepolizumab, the earliest studies done on this drug, so we're directing now IL-5 therapy, were done on non-specific populations. They kind of had mixed results where it would bring down eosinophils in the blood and sputum, but they really didn't see any improvement in the quality of life or any improvement on spirometry. So, troubleshooting their poor results. So when looking at the efficacy of treatment, they were asking themselves, is the right population being studied? So they started getting more specific with the target that they were going after. It starts out with this study published in the New England Journal. Mepolizumab can be used as a glucocorticoid-sparing agent in eosinophilic asthma. It's a previous proof concept study of IV Mepolizumab was effective in preventing exacerbations. They looked at Mepolizumab's effects on reducing oral steroid use while maintaining symptom control. It was a random, double-blinded, placebo-controlled parallel group study. They looked at 135 patients with severe eosinophilic asthma. There were 4 phases: optimization of oral steroids, induction, reduction in oral steroids, and maintenance. 100 milligrams of Mepolizumab subcutaneously every 4 weeks for 20 weeks. And then here's some of the outcomes. So when they looked at this, the Mepolizumab group had 16 patients that had 90 to 100% reduction in their glucocorticoid use. So, and then as we go down, so there were more 75 to 90% reduction in 12 patients, and then 50 to 75. But there is a group of patients right here that had no decrease in oral glucocorticoid use. So again, going back to some of the heterogeneity in asthma, is that it's not all the same. The changes in oral glucocorticoid dose, rate of exacerbation, and asthma control when looking at it. So at 24 weeks, the median percentage of the steroid dose was reduced in 50% of the Mepolizumab group. They had a 32% reduction in asthma exacerbation, and their ACQ-5 improvements observed as early as week 2 and sustained through week 24 of the study. So, looking back at this, so asthma exacerbations requiring hospitalization and pneumonia were most frequent serious adverse effects in the placebo group. There were significantly greater reductions in maintenance oral glucocorticoids use in the Mepolizumab group. and significantly beneficial effect on exacerbation, asthma control, and quality of life. So they found when they targeted a more specific group of patients, they got better results. So it was decided that it was safe to reduce steroid dose in severe steroid-dependent eosinophilic asthma patients, but unclear if the duration of the trial is sufficient to see complete withdrawal of steroids. This Mepolizumab treatment in patients with severe eosinophilic asthma by Ortega et al. Also published in the New England Journal at the same time. This looked at 576 patients. They had to have had 2 exacerbations in the past year, blood eosinophils greater than 150 at screening or greater than 300 in the past year. And they got a 40-week duration of 100 milligrams of sub-Q and 75 milligrams IV. Those are 2 different groups. So in the IV group, they found a 47% reduction in exacerbation, and they found a 100 cc increase in the FEV1. So this is the study that started showing improvement in spirometry. And the sub-Q group had a 53% reduction in exacerbation and a 98% increase in FEV1. And that led to the DREAM trial, which looked at 621 patients. They looked at patients that had greater than 3% sputum eosinophilia. The peripheral eosinophilia was greater than 300. They randomized placebo versus Mepolizumab. Results were exacerbations reduced from 2.4 to 1.5 per patient per year. And they also confirmed the decrease in peripheral eosinophilia and sputum eosinophilia. In November 2015, FDA approved Mepolizumab for severe asthma with eosinophilia. So another drug that's being looked at is Mepolizumab, which is a humanized IgE, mAb binding IL-5. Early studies showed reduction in peripheral and sputum eosinophils, and it also showed a trend in increasing the FEV1. And it had fewer adverse effects. So a phase 3 trial that I came across was 492 patients on medium dose inhaled corticosteroids. Primary outcome that they looked at was improvement in the FEV1 from baseline to 16 weeks. When they looked at just a non-select group of patients, they found that there wasn't much improvement, but when they narrowed it down to a more selective group, looking at eosinophils or the severity of their asthma, they found an improvement of 270 cc's when the eosinophils were greater than 400, but no improvement in FEV1 when the eosinophils were less than 400. So Mepolizumab is another medication. This actually is directed at the receptor. It's still under study. There is worry that the anti-IL-5 alone therapy is insufficient against the fight against eosinophils, and it's expected to act on cells that express the actual IL-5, specifically the basophils and the eosinophils. So some of the questions that we ask about these medications is safety. Most common side effects are headache and nasopharyngitis. There's hypersensitivity reactions to sub-Q medication, so sometimes they get a reaction, site infection, urticaria, angioedema. It's administered, under medical watch and medical supervision. And there were 2 cases previously that I came across of reported herpes zoster. So the cost, everything comes down to money. We remember Amber's talk yesterday. So does the cost outweigh the benefit in this patient population? So what you're telling me is you can't afford your breathing medications, but the cigarettes, hanging out the purse must have been free. But no, this is much more costly than an inhaler. The estimated cost of anti-IL-5 therapy, Mepolizumab specifically, is approximately $32,000 a year when you pay out of pocket. I went to Xolair's website, and they do provide assistance and means if you fill out some paperwork. So some of the questions that they still need answering is, the parity is, who got better and who did not in previous studies. There were some people who received Mepolizumab in the first trial, and they had 100% reduction in their oral corticosteroid use. There are still 25% of people who had no change. So they always saw improvement when they had selectivity. And one of the things they discuss is, sputum eosinophils. Maybe that's something that needs to be monitored but not every facility monitors or has the means to monitor sputum eosinophils. Another question is, how long do we treat for? So majority of studies were done for 12 months. And then what happens when we stop treating? A lot of people saw a rebound in their eosinophils and symptoms. One of the things I came across is a study where they're looking at people who have been on it for 3 years, maintenance, and been controlled with the Mepolizumab. What's going to happen to them when they wean off or stop? So some of the inclusion criteria for anti-IL-5 therapy. As we discussed, some of these patients are really sick, they're on high-dose steroids, and they need eosinophils they need a high eosinophil count to maybe qualify for the medication. So, I gave a scenario here, because we all love to text, of, a text message with an insurance company. We're the blue one, asking if they're up. So we're saying we're having trouble breathing and we want some MABs, and they respond, sorry, your eosinophils are way too high, you can't have them. We explain that they're high because we're on the steroids. They're low because we're on the steroids, I apologize. So their response is, come down on the steroids, recheck the eosinophils. If they're higher, we might be able to help you. So in theory, the meds that are kind of helping them get by with a poor quality of life kind of hinder them from getting medication that may potentially benefit them. So that's, what we're asking. You want us to stop this medication in the hopes of being able to get the other medication. And it's really all in the game with the insurance company. So, and they also always want the prior auth when you get approved. So, going over patients that, the other therapy that I'm going to discuss is the IgE therapy. So this is somebody that I saw with Dr. Ouellette on K17, and I thought it would be nice to use as an example in this story. So Miss LB, she's a 65-year-old female with past medical history of severe uncontrolled asthma. She was first seen in the pulmonary department clinic post-hospitalization for asthma in 2015. Since then, multiple hospitalizations and ER visits for asthma exacerbations. Prior to that hospitalization in 2015, she had no respiratory issues. So she's on Advair 550 and requiring intermittent prednisone therapy for exacerbations. She's not seen a pulmonologist since March 2016. She's also seen the allergist for asthma. She reports around-the-clock albuterol use with minimal relief. The only thing that gives her relief is PO steroids. So they drew an IgE level on her, and it was 646. They also did an allergen panel on her that was positive for dust mite IgE and the DF and dust mite IgE DP. So here's her PFT from March 16th. Does show some obstruction. She's got a FEV1 VC ratio of 64. So Allergy gave some input to her, and they told her, you may qualify for Xolair, but you need to prove adherence to high-dose therapy for at least 6 months. You also need to show that you're having exacerbations, and you also need to show that you're occasionally requiring PO steroids. So when she came to see me on the December 13th, not really much change in her PFTs. So, and she was still very symptomatic. She had just gone to the ER a month earlier and required oral steroids. So, we'll return to her shortly. So we'll get to omalizumab, which is an IgE-directed therapy, and it was FDA approved in 2003 for the treatment of moderate to severe persistent allergic asthma. It was targeted towards allergic asthma that was not adequately being controlled with high-dose inhaled corticosteroids. So just the way that it works, or the process behind it, is we have an allergen that gets taken up by dendritic cells, and then it gets engulfed, and that creates an antigen on the surface, and that leads to the T cells presenting to B cells and release of cytokines, and then you get some formation of this IgE receptor. So the next time you get exposed to that antigen, they go to the IgE receptor on the mast cell and cause mast cell degranulation, which causes a lot of this airway constriction, mucus secretion, and causes a lot of their shortness of breath. So again, this is the top part, shows us, how this goes down with the FCER2 binding site of the IgE to the mast cells, and then causing or the plasma cells to release the IgE, and then you get the inflammatory mediators. And then here you see the omalizumab IgE complex, all right, and it binds it. It prevents the IgE from binding and causing the degranulation. So, looking at benefits of omalizumab and add-on therapy in patients with severe persistent asthma who are inadequately controlled despite best available therapy, the INNOVATE. So, what's the effect on omalizumab on clinically significant asthma exacerbation? Looked at 419 patients. Some of the inclusion criteria was an age between 12 to 75 years old. They needed alloallergen positive on the skin test, and a serum IgE level that was greater than 30 but less than 700. And they also needed to show that despite the high dose inhaled corticosteroid and LABA use, they had two asthma exacerbations requiring systemic steroids, and a FEV1 greater than 40% but less than 80% predicted normal with persistent asthma symptoms. So very similar almost to what the allergist office told our patient. So when they looked at this and compared what happened in those on omalizumab compared to placebo, they found that there was a clinically significant decrease in the asthma exacerbation rate, as well as the severe asthma exacerbation rate. So it showed that the omalizumab helped these people with some of their exacerbations. So back to my patient, I discussed her with Dr. Roulette, and one of the first questions he asked me was, if her eosinophil level was greater than 700, would you treat her? And I said, I don't know, but, sure. And, he asked me to look up the study, and I went over it. So the total serum IgE level more so helps direct dosing, not the treatment. So people who have an IgE level greater than 700, there's no dosing recommendation for them on how to deliver omalizumab. The Europeans go up to an eosinophil level of 1500. IgE, sorry. Getting the two mixed up, apologize. So we got her approved, and the other thing was it's weight-based and based on the IgE. So she got approved, and she's receiving 375 milligrams every 2 weeks. I last saw her on the 18th, that would be maybe 2 weeks ago. She states she's feeling well, and plan to follow up with her in February. So some of the things that I thought about with her when I got her started on this is, how do I monitor her? What am I looking for? So that's one of the things that I was looking at. And really, the response to treatment is just best directed by physician assessment. Seeing the patient, getting a history, finding out, how symptomatic is she, what she's been going through. And then, and that's about it. The total IgE, as I spoke, you don't monitor that to look at how she's, being treated and how she's responding. That really just drives the dosing. The total IgE levels will remain elevated during treatment because it's bound to omalizumab. So the thing that you would want to look at would be the free IgE levels. And it says that when we get to a level of free IgE that's less than 50 nanograms per deciliter, that's when we see some clinical benefit.